Today we're going to be talking about the gluteal region. If you ever have any questions, please feel free to email at my email address listed here. I organize my slides by learning objectives, so you will see these interspersed throughout the lecture presentation today. The area of interest for each section will be shown by these red highlighted areas. So let's get started and talk about the osteology of the hip. So first, let's talk about one hip bone. You have a right and a left hip bone that actually is attached at the sacral level. But of these one hip bones, they are composed of actually three different parts. You have the ilium, which is located superiorly and makes up kind of the traditional wing-shaped look of the hip bone. Then you have the ischium, which is located inferiorly and posteriorly, which is quite thick part of a bone. And then you have the pubis, which is going to be the most anterior portion of the hip and actually will help create that pubic symphysis area that's right in front, right at your groin. These bones are actually separated for most of your childhood, where they have a cartilaginous region in between them that slowly ossifies. And usually this is finished between, this ossification is finished between age 20 and 25. So now we're going to look at the individual features of a hip bone. And in this image here, this is a lateral view. So if you put your hand on the outside of your hip, this is the area that we're looking at. Anterior is going to be towards the right of your screen, while posterior will be to the left of your screen. So starting superiorly, we have kind of three main things. We have the ala, which is going to be that wing shape. And the ala is really only referred to this lateral view. Once we look at the medial view in the next slide, this name will actually change. This ala is bordered and is created the superior border by something called the iliac crest. This is something that is very easily palpable and is just the thickened edge of the hip bone. And then on the anterior side, we have something called the ASIS. This is an abbreviation for the anterior superior iliac spine. Spine typically means a protuberance or a bump. There's a few different names that are given to these bumps, but it is kind of the end of the iliac crest on the anterior side. One thing that you'll learn with anatomy is that there's always, if there's one, there's the opposite. So this is a superior, so there must be an inferior. In this image, the anterior inferior iliac spine, the AIIS, is not as visible, but we'll see that more in the medial view in a minute. Now moving posteriorly, we have several more things. So on this side, you'll notice two kind of indentions. One is called the greater sciatic notch. So this is going to be the larger and more superior of the two notches of the hip. And this is bracketed by the PIIS, so the posterior inferior iliac spine on the superior edge of this greater sciatic notch. And then on inferiorly, it is bracketed by the ischial spine. Now the ischial spine separates the greater sciatic notch from the lesser sciatic notch. And while the greater sciatic notch, it looks like kind of someone took a baseball bat to the hip and created this really big indentation, the lesser sciatic notch is much less evident. For me, the greater sciatic notch is the easiest way to tell what is posterior and anterior of the hip, because that is going to, for me anyway, it sticks out as one of the more evident anatomical structures of the hip. Then kind of moving on the inferior side, looking at the ischium and the pubis, we have the ischial tuberosity. This is going to be something that you can kind of cup in the palm of your hand. It's a very thick bone because this is what our sit bones are. So like if someone sits on your lap and you are like, oh, you have a really bony rear, this is usually the ischial tuberosity coming through all the muscles that try to cover it. So it's a very strong bony part of the hip. Then we have the pubic tubercle, which is really the only thing on the pubis we're going to spend most focus on in this lecture. And then this is going to be an attachment that will come up throughout the semester, especially in the abdomen. and it kind of brackets that pubic symphysis area. Now the ischium and the pubis both kind of join together and create something called the obturator foramen. Foramen means opening. Obturator is just where we have some structures of a similar name come through. And then lastly, we have something called the acetabulum. Now, the acetabulum is going to be the kind of circular portion. You can kind of stick your fist into it, and this is where the head of the femur actually sits. On the lateral view, this helps you kind of orient where you are, but of course, when we move medially, we lose this. So again, try to find something that is very evident for you on what is anterior and posterior and medial and lateral view. So now let's move medially. So we still have our iliac crest. Remember that superior border of the hip. The ala now becomes something called the iliac fossa, and that's because a muscle called the iliacus actually sits in here. So a lot of times these fossas have a muscle of a similar name. On the anterior side, you can see the greater side notch on the posterior side, but on the anterior side we have, that end of the iliac crest as the anterior superior iliac spine. And if you look slightly below that, inferiorly to that, you see another kind of small little bump or protrusion, and this is your anterior inferior iliac spine. Moving posteriorly, we have a posterior superior iliac spine. This is not what creates the superior kind of end of the greater sciatic notch. That would be your posterior inferior iliac spine, where on the anterior side, the ASIS or the ASIS is a little more evident than the AIIS. On the posterior side, it's just the opposite. The PIIS is more apparent than the PSIS, and that's mostly because of that greater sciatic notch right below it. So you see the big kind of indention, the greater sciatic notch, separated from the lesser sciatic notch by the ischial spine. And then we still have our ischial tuberosity, not quite as evident in the medial view because it's more of a lateral protrusion. Then we have the pubic tubercle on the pubis portion anteriorly, and then where the pubis and the ischium kind of join together forms the obturator foramen. And because this is the medial view, so this is where prostate, rectum, all of those internal pelvic structures set, there is no acetabulum. That is only for the lateral view for where the head of the femur sits. So with these kind of bony named areas of the hip, there's only a few of them that we can use for surface anatomy. So for palpation, kind of one of the bigger ones is the anterior superior iliac spine, that ASIS. Basically, if you have a patient laying on their back, if you put your thumb kind of to a mid-clavicular line, so if you draw a line from the mid of their clavicle all the way down, you should be able to find the anterior superior iliac spine. Then if you move laterally, you can actually palpate the iliac crest, and you should also be able to feel that iliac crest when a patient is on their stomach. You also have the intergluteal cleft or the butt crack, but really the iliac crest and the ASIS are going to be your most palpable areas of the hip. Now you can feel portions of the femur and you can feel portions of the sacrum and coccyx, but of the hip, ASIS and iliac crest are really your two main ones. Mentioned earlier that your right and your left hip are joined by a sacrum, and this kind of posteriorly joining to the sacrum and also the anterior joining of both sides of the pubis to create the pubic symphysis create something called the pelvic girdle. Now we still have our iliac crest superiorly, that ASIS anteriorly. Those are the two really easily palpable areas. And then you can also palpate the pubic tubercle on some people. They usually have to be pretty thin for you to be able to palpate that. Keep in mind that we have the femur going into the acetabulum area. I do want to mention a couple of features of the femur just because those are going to be attachments for some of our gluteal muscles. So we have the head of the femur. The If there's a head, there's a neck. So the neck is usually the thinnest part and usually the most easily damageable. Then we have something called a greater trochanter, and this is going to be another kind of bump protuberance on the lateral side of the hip. Then if there's a greater, there's a lesser. The lesser trochanter is going to be more medially located and is a protrusion off the posterior side of the femur that we can see medially. One last thing I do want to make a point of is that the iliac crest, the most superior edge of the iliac crest, is usually at vertebral levels L4, L5. This is important because this is typically where a spinal tap, so going into the spinal column to get like something like CSF out to check for an infection or pressure or something like that, they typically use the iliac crest as a good landmark for trying to find where that L4, L5 is. So keep that in mind. Because our gluteal region is very bony, so there's a lot of these protuberances that we talked about, a lot of these bumps. There's also a lot of muscles that create a lot of friction. And so one thing that tries to help reduce this friction and kind of reduce some of the pressure points directly on those bones are these things called bursae or bursa. Bursae is the plural, bursa is the singular version. So basically all throughout your body at these highly movable kind of bony areas, we have these bursa. And these bursa are basically just synovial filled membrane sacs. So if you've ever heard of synovial filled joint, it's that same fluid, but instead of it being at a joint, it's literally a membranous sac that's filled with that same kind of viscous jelly type of synovial fluid to help reduce pressure and also friction, like I said. In the gluteal region, we have three main ones. The first one in blue is going to be the trochanteric bursa. And so trochanteric, you think trochanter, so this is actually going to be over the greater trochanter and helps kind of protect that lateral side of your hip. Then you're going to have a gluteal femoral bursa, which is in purple, sitting on top of the femur right over the gluteus maximus, which is where the gluteal, so gluteus maximus, femoral over the femur. Next we have is the ischial bursa. This is going to be in the ischial region, particularly over the ischial tuberosity. Remember that sit bone area where someone, if you say, oh, we've got a bony butt, that's that area. So these are high pressure areas that also have a lot of muscles that attach to them that we'll talk about in a little bit. Now, like anything, these bursa can become inflamed with something called bursitis. Anytime you see the ending itis, it usually means inflammation. One of the more common ones is with trochanteric bursitis, so right over that greater trochanter of the femur, because one of our kind of long tendinous bands is going to be the IT band that rubs right over this greater trochanter. Usually this is caused by any sort of stair climbing or any sort of incline, basically, can put pressure on that area. The next most common one is going to be the ischial bursitis, so right over the ischial tuberosity, and a lot of times it's called from cycling, so just from a lot of sitting and irritating that bursa sac. Now the hip or the pelvic girdle is not held together just by bones and muscles. They have ligaments that actually go from bone to bone to hold them together at these joint type areas. Now there are a lot of ligaments of the hip that we're just not going to talk about. Probably we will talk about more of them later on in this semester, but the two most important ones for this lecture that I want you to know are something called the sacrotuberous and the sacrospinous ligament. So you have both an anterior on the left and a posterior on the right view. For these two ligaments, usually we're going to be coming at it, especially in anatomy lab, through the posterior view. And really it's easier to see both of these that way. So the sacrotuberous is going from the sacrum to the ischial tuberosity. You can see there, so that's where the name comes from, and it is going to be the more superficial of the two ligaments. It is going to go from a superior to inferior type of direction, so kind of more of a vertical direction. The sacrospinous ligament is going to be just deep to the sacrotuberous ligament, and that is going from the sacrum to the ischial spine. That's where that name comes from. And so instead of that superior to inferior type of movement, this is actually going from a medial to a lateral, so right to left. They create this kind of crisscrossing pattern with each other. That'll be very important when we talk about the pudendal nerve artery vein bundle at the end of this lecture. And these will be two ligaments you have to find in anatomy lab, as well as the nerve artery vein structures that are associated with it. So sacrotuberous ligament is going to be superficial to the sacrospinous ligament. Sacrotuberous ligament is going to go from a superior to inferior, where the sacrospinous ligament deep to it is going to go from medial lateral. Those are the big kind of points there. Now, these ligaments, in addition to the obturator membrane, which is just within the obturator foramen, create kind of additional foramen as well as covering up that big large opening. So when we talk about the obturator membrane that is in the obturator foramen, basically covers the entirety of this big hole in the hip to create more of a smaller hole, because really all that we have coming through there are nerve arteries and veins. Now, on the other hand, your sacrospinous ligament and your sacrotuberous ligament, these help take that greater sciatic notch and the lesser sciatic notch and actually form the greater sciatic foramen and the lesser sciatic foramen. So these ligaments not only help kind of anchor the sacrum to the hip bones, they also help create these openings for structures to pass through. So that's all on the osteology. Now let's talk about the muscles of this area and their innervations in arterial supply. So really for the muscles, we are going to give you two attachments, an action, and a nerve innervation. So for my lectures, I use P for proximal, so the closest attachment, D for distal. A for action, this actually says hip A action because that's important. This has two different actions in this particular muscle. And then I for innervation. A lot of times you might see the proximal and distal listed as insertion and origin, where origin is typically the proximal and distal is typically the insertion. The reason I don't use that is because depending on the action, the origin and insertion can actually switch. So proximal and distal are my preferred labels. And so you'll see these abbreviations throughout all of my lectures. So first, let's talk about something called the tensor fascia lata. It kind of sounds like some drink you could get at Starbucks, but it's actually going to give us some good information. So for the tensor fascia lata, often abbreviated, as you can see here, is the TFL. This is going to be a very thin muscle located in the gluteal region that attaches at the asis and the iliac crest, so kind of towards the anterior side. This muscle doesn't really go much further than a few or several inches before it becomes an actual tendinous band, a very long, flat tendinous band. And that tendinous band will attach distally to something called Gerdy's tubercle. And this is going to be on the lateral side of the knee. The action for this guy is going to be a lot of flexion, abduction, and medial rotation, even though all of these are fairly weak. There's a lot of other muscles that do a lot more than that. And then the innervation is going to be superior gluteal nerve. So here in this image, they show the TFL as a thin muscle, that long, kind of thick, distinct iliotibial tract. When we actually go into lab, this will not be the case. When you are looking for the TFL, you will actually see mostly just white fascia. And that's because if you cut the fascia, you will then actually see the very thin little muscle called the TFL. And especially in our donors, because they're older, these muscles are going to be a little smaller. So if you had someone who was younger and healthy, especially someone who did a lot of running and things like that, they would have a better TFL. And then the iliotibial tract, you'll actually create your own from the fascial compartment that lines the thigh muscles that will be talked about later. Next, we have the biggest muscle of this region called the gluteal maximus. And so when you strip off all the skin and the fat of your donor, this will be the muscle that you see most evidently. This muscle, it's called maximus because it's huge. It attaches to a lot of different things. It's kind of indescript in that way. Proximally, it basically attaches to the ilium sacrotuberous ligament. Point out the sacrotuberous ligament because when we actually reflect the gluteus maximus, a lot of times the sacrotuberous ligament is cut because it is attached on the underside of the gluteus maximus. So whenever you do your dissections and when we reflect it, when you put your hand underneath the gluteus maximus muscle, find that sacrotuberous ligament and try to save it. And then distally, it's actually going to attach to the iliotibial tract. You can see all those kind of little muscle fibers attaching all the way down that IT tract. This is the main extensor of the thigh. And so basically what this means is that when you go from a sitting position to a standing position, that extension, the elongation of the trunk and of the hip area is going to be your gluteus maximus. So that's why squats are very effective at kind of giving you a better contour of your gluteal region because you're working out this huge muscle. And then this guy is innervated by the inferior gluteal nerve. Remember, inferior gluteal nerve, and why it's the inferior gluteal nerve will become evident in a little bit. If there's a maximus, then we probably have different other muscles, and there's actually 3 of these gluteal muscles. The second most biggest is going to be the gluteus medius. So it's called medius because it's the middle of the two. Gluteus maximus kind of sits on top of it. The next muscle, gluteus minimus, actually sits deep to gluteus medius. This is going to attach basically all around the ala of the hip to something called gluteal lines. Can't really see them, but ala of the hip is perfectly fine. So that lateral kind of indentation, that lateral wing of the hip. And then it's going to go all the way to the femur and attach at the greater trochanter. The gluteus medius kind of attaches to the lateral, slightly anterior portion of the greater trochanter, and that'll become a little more important later. This is going to be for hip abduction. So abduction is moving the leg away from the body, so moving it laterally, and medial rotation. Abduction and the rotation of the hip are different. So abduction is literally keeping your body on kind of that coronal plane and just moving it outwards, moving it laterally. While medial rotation is actually taking your femur and rotating it into your body. So if you've ever done like high knees where you have to like step up and step in, that is going to be medial rotation and is a very important muscle for walking. This is going to be innervated by the superior gluteal nerve. So gluteus medius is going to be slightly deeper to the gluteus maximus, but sits on top of our next one. And that is the gluteus minimus. So you have to, in this image here, the gluteus maximus has been cut and the gluteus medius has been cut. You can still see the TFL on the lateral side, that very thin muscle, that's the most lateral muscle. And then you have the gluteus minimus, that sits on the ala of the ilium. And it also goes to the greater trochanter and attaches just a little more anteriorly than the gluteus medius does. It also does the same exact actions as the gluteus medius and has the same innervation. So hip abduction, moving it laterally away from your body, and medial rotation. So moving your thigh inwards. So kind of taking, I guess a better way of describing that is taking your knee where if you sit and your knee is very parallel, if you move one knee to where it touches the other knee, that is medial rotation. And then innervated by superior gluteal nerve. So gluteus maximus is going to be inferior gluteal nerve. Gluteus medius and minimus is going to be the superior gluteal nerve. It has nothing to do with the size of these nerve bundles. It is more just where they are in relation in the hip. And again, we will get to that at the end of this lecture. One easy way to test for the superior gluteal nerve injury that innervates both the gluteus medius and minimus is something called the Trendelenburg test. And because these two muscles are really big with that abduction medial rotation, they really help with swinging the leg forward when we go to take a step. And so, using this Trendelenburg test, you can actually look at the hip levels to tell which side of the hip is injured, or which superior gluteal nerve injury, whether it's the right or the left, is injured. To do this, basically the injured side is going to have the hip rise with pressure. So when they put that step, your hip is going to, so like on this, if they're walking away from you, where their right side is your right side. When they step, that right hip is going to go up if it's a right-sided injury. On the opposite side, the left side is actually going to decrease, creating, instead of a parallel like iliac crest, which is going to be that straight blue line on the superior side, your iliac crests are then kind of wonky, where the right side is up in the air and the left side is down below that level, that horizontal level. And it does this because of compensation. So when this nerve is injured, we get something called a gluteal limp. So that's where your weight is shifted over that injured hip. So I have right and left labeled here. So you lean to the left side, you hike the right hip. So that's that right hip going up in the air. You get something called a steppage gait on the right side. And then you get circumduction with the right side. And
then come back, turn and come back.
this is what that gluteal limp looks like with the Trendelenburg test. So this patient is walking away. You can see that actually her left hip increase in the air. And when she turns, it actually looks a little more prevalent, where you can see her kind of lean over, hip height. Okay, so next we've moved out of all of our gluteus muscles, and now we're going to get into a lot of these small, short muscles of the hip. If you can look at this image here, again, the gluteus maximus and the gluteus medius have both been cut away. We can still see that small little gluteus minimus going to the greater trochanter. And then you see a lot of small little muscles. The first one that we're going to talk about is called the piriformis. So piriformis actually means pear-shaped. I don't know where they got that from, because when you look at it in lab, this does not look pear-shaped. It is more of a triangle, where the base of the triangle is going to be medial and the apex or the point of the triangle is going to be towards that greater trochanter area. That's because the base attaches to the sacrum proximally, and then the point, the apex, is going to attach to the greater trochanter. This is your main landmark in the hip. Basically, anything that you look at for anatomy lab is going to surround and going to be based off of location of piriformis. So if you can't find anything else in the hip, piriformis is your friend. This is going to be a lateral rotator of the hip, and it doesn't have really any fancy name other than it's innervated by S1 and S2. Now we're going to move inferiorly, and all of these next muscles are all going to move inferiorly. We then have something called a superior gemellus. A lot of times it's called as the superior gemelli. This is going to be just inferior to that piriformis muscle. It's going to go from the ischial spine, again, over to the greater trochanter. Same thing, lateral rotator of the hip. Basically, all of these 5 muscles are going to be lateral rotators, so keep that in mind. Once you hit piriformis and move inferiorly, all lateral rotators. And then this guy is actually going to be innervated by nerve to the obturator internus. And the obturator internus is actually the next muscle inferior to that superior gemellus. This is going to go from the obturator membrane. Remember that we talked about covering the obturator foramen, and then go laterally to its distal attachment of the greater trochanter. Again, lateral rotator of the hip. Innervation is nerve to the obturator internus. So both superior gemellus and obturator internus are innervated by nerve to obturator internus. Here they show the obturator internus as very muscly with a small little white tendon distally. This is not usually true. Typically, to find the obturator internus, you want to look for the shiny tendon that sits between the superior gemellus and the inferior gemellus, which is the next muscle we'll talk about. So, tendon separating both of these two muscles. The inferior gemellus, just mentioned, is located inferiorly to that tendony obturator internus. This is actually going to attach to the ischial tuberosity instead of kind of a more superior area because we're moving inferiorly in the hip and go over to the greater trochanter. Again, it's below the piriformis, so it is a lateral rotator, and it is going to be innervated by nerve of the quadratus femoris. So remember that the superior gemellus and the inferior gemellus are separated from each other by the obturator internus. So that's one good way to keep that in mind. Next, the most inferior gluteal muscle that we're going to talk about is called the quadratus femoris. It is going to go from the ischial tuberosity over to the intertrochanteric crest of the femur. So this intertrochanteric crest is going to be a kind of ridge on the posterior side of the femur that kind of connects the greater trochanter to the lesser trochanter. This is a fairly easy muscle to see because it is quite square. That's where the quadratus came from, and then it's going over to the femur. So that's where its name came from. Again, it is inferior to the piriformis, so it is a lateral rotator, and it is going to be innervated by nerve to the quadratus femoris. So, piriformis is innervated by S1, S2. Nerve to obturator internus is going to innervate the obturator internus and the superior gemellus. And then the nerve to quadratus femoris is going to innervate the quadratus femoris and the inferior gemellus. So again, using the obturator internus as kind of a separating tool for finding it. And also innervation is also fairly easy. But remember, piriformis is your key landmark of the glute. If you can't find piriformis, you're really going to struggle on identifying a lot of these muscles. So just putting it all together, with all of these gluteal muscles that we talked about, we basically have three main functions. So we have hip extension, we have medial rotation, and abduction, so swinging the hip laterally, pulling the knee medially. Then we also have lateral rotators. How I like to talk about lateral rotators, if you've ever played soccer and you go to pass the ball with the arch of your foot, you're laterally rotating your knee because even though your hip is stable, you swing your knee laterally, causing lateral rotation. So for our hip extensors, biggest one, gluteus maximus. Remember, squats. That's what you're working when you're doing that, is extending your hip on your trunk, going from that sitting to a standing position, gluteus maximus. We then have lateral rotations. So these are all of the piriformis and inferior muscles. So piriformis, superior gemellus, obturator internus, inferior gemellus, and quadratus femoris. All 5 of those muscles are lateral rotators. Then we have medial rotators located superiorly, and this is going to be the gluteus medius, which is cut here, and the minimus. So kind of grouping these things together will help you organize the gluteal region. So now we're going to talk about why you can have these 3 different actions involving muscles that attach to basically the same thing in the same region. And that is due to something called an angle of inclination. And it basically is what allows these muscles to be located in the hip and also be short and act quite largely on this long bone. And really, the angle of inclination is big for walking movements. So we talked earlier basically about medial rotation and lateral rotation. Both of these rotations help give circumduction to the leg, so allow our swinging of the leg to allow us to propel forward or backwards, however we should want. So with the medial rotation, that is going to be with our gluteus medius and our gluteus minimus muscles. These are both 2 superiorly located muscles that attach on the anterior side of the greater trochanter. So those are going to be those kind of light blue arrows. And in the image to your right, you can see how they kind of wrap around to the front of this anterior view, where the minimus sits more anteriorly than the medius as attachments onto that greater trochanter. Now your lateral rotators, so this is going to be your piriformis, superior and inferior gemellus, obturator internus, and quadratus femoris, these will actually attach more to the posterior side of the greater trochanter. They do sit a little more inferiorly, but they are still superiorly located on this long bone region, so the thigh bone, the femur bone. So what this looks like when walking is that medial rotation typically occurs on your planted or your fixed limb to help swing your advancing one forward through lateral rotation. So you are going to use lateral and medial rotation on the swinging limb to create that circumduction, but usually the swinging, so kind of the anterior movement going to a planted, is going to be your medial rotation, and your lateral rotation is going to be that more posteriorly placed leg that is starting its forward movement. So medial rotators are attached anteriorly to the greater trochanter. Lateral rotators are attached posteriorly to the greater trochanter, and this allows for that laterally driven lever to work kind of oppositely, these placements, and give us our steppage gait. Now, this angle of inclination, even though it does decrease as we get older, you can have two variations, either a severe decrease or severe increase of this angle that can affect movement. So coxa vara is going to be your decrease, your severely decreased angle. This image here is showing more of a 90-degree angle. If you looked at earlier, typically 125 for a middle-aged person is pretty normal. So losing basically 30 degree angles can severely affect how you walk. Coxa vara is also commonly referred to as knock-kneed, so your knees being close together. On the opposite end, the severely increased angle is going to be coxa valga, or bow-legged. So this is where they kind of set a little wider. And then these can go up to close to 180. So this is going to be more around the 160 degrees area. So coxa vara is going to be a decrease in angle of inclination. Coxa valga is going to be an increase in the angle of inclination. So let's now move on to our last subject for today, and this is going to be looking at nerve innervation and arterial supply. We've already talked about the individual nerve innervations of the muscles, but we haven't talked about their locations, so that's what a lot of this is going to be. We're first going to start kind of superficially and then move deep. So superficially, we're going to talk about cutaneous innervation. Anytime you hear cutaneous innervation, that usually means skin innervation. So dermatomes is skin innervation. When we talk about the cutaneous innervation of the lower limbs, we really need to start out with embryology. And that's because these dermatomes that are very kind of flat, especially in the chest area, and even to some extent in the arm area, actually change when we get to the lower limb. And that's because this lower limb, which is the kind of embryonic predetermination of the lower limb, once it starts kind of growing larger and becoming more like a leg, it actually starts twisting. So instead of straight lines across, and even where these straight lines kind of lead into the arm, as you can see in this image, they actually twist. So like wringing a towel is how these dermatomes are going to look. And that's what this looks like in an adult. So you have an anterior and posterior view. The purple are going to be your lumbar nerve innervations. The green are going to be more sacral. So when you look at the front of the leg, your dermatome patterns are mostly L1 through L5 in this kind of wringing a towel type of look. L1 is going to be very close to the groin, and then as you move inferiorly, this will become a lower lumbar nerve segment, but also kind of get longer in their twisting. You really can only see a sacral innervation at the pinky toe, and that's going to be S1. When you move posteriorly, this ringing kind of stops, and that's just with the development of the lower limb. And that's when you get the S1, S2 running down the back. That's going to be like your sciatic nerve. If you ever hear of sciatica, that's that general pattern running down the back of the leg. Now, in these dermatome areas, we actually have cutaneous nerves that are named. So a dermatome and these cutaneous nerves that are named are both sensory nerves to the skin, but dermatomes are typically by their vertebral level, and these cutaneous nerves are based on their name. They're typically a region. For us, we're really going to look at the cluneal nerves. So cluneal means buttocks, which basically tells you where they are. And really the big ones are going to be your superior, middle, and inferior cluneal nerves. We will not see any of these in lab. They will all be destroyed, but keep that in mind, where your superior is going to do most of like your gluteus maximus. The medial is going to do kind of more over the sacral area. And then the inferior is going to kind of come out at that inferior border of gluteus maximus. A couple of others that I want to mention is going to be the posterior cutaneous nerve of the thigh. It's also called the posterior femoral cutaneous nerve. Either one is fine. This is actually a branch off the sciatic nerve that we'll talk about in just a moment that goes and does the sensation to the entire back of your thigh. You also have a few others where you have the lateral cutaneous nerve of the thigh that will be talked about in another lecture, and then the iliohypogastric nerve that we talk mostly about in the abdomen. Okay, so now let's look at these nerves, and we're also going to add some arteries and veins as they're located in the gluteal region. Now, don't freak out too bad, because other than one instance, the nerve, artery, and veins are going to have the same exact name, and they typically go to the same exact area. So first, you have your gluteus maximus reflected. That's that cut muscle. You can see the gluteus medius, and then you have the piriformis. Remember how I said the piriformis is your main landmark of the leg? Well, this, talking about the location of these nerve, artery, and vein bundles, is why. So, looking at the piriformis, you see that big nerve coming out. That is your sciatic nerve. So that's doing almost all of the innervation of your thigh and of your leg and foot. The sciatic nerve is quite large, as this image shows. It's going to be about the width of your thumb. We say this every year, and every year someone cuts it, but please do not cut it. It is very large for a nerve, yes, but it is still a nerve. It just has a lot of axons in it because it's innervating a lot of things. It is going to come out under the inferior border of the piriformis and then travel inferiorly to go to the thigh. Typically for me, finding the sciatic nerve and working the way up and finding where it kind of goes underneath the gluteus maximus is the easiest way to reflect, but that's just one way. Next, kind of medially to the sciatic nerve, we have the posterior cutaneous nerve of the thigh. So remember that sensory nerve to the skin that does the posterior thigh. It's also coming out on the inferior border of the piriformis, but it is just medial to the sciatic nerve. Now, most of you will cut it, but some of you will keep it intact. So we'll hope for some of you keeping it intact. Now we're going to move on some of these other vasculature. So also in the inferior border of the piriformis, we have the inferior gluteal nerve, artery, and vein. In lab, you will have to tell apart a nerve, artery, and vein. That's part of the challenge. Nerves typically have a straight path with kind of an off-white look. Arteries and veins will typically be more curled. Arteries have a pinkish hue to them. To me, anyway, veins have a little more of a purplish hue to them. Arteries are also much thicker in their vascular wall, and that's because arteries actually have a muscular layer in between as the medial layer of the artery, while veins don't. They use valves to pump blood, while arteries use muscles. Because of these muscles, if you look really closely at arteries, especially the large arteries, you can usually see little purple splotches, and those are small little capillaries feeding that muscular layer. So keep that in mind. So on the kind of a recap, on the inferior border of the piriformis, you have the sciatic nerve laterally, huge, you can't miss it, please don't cut it. Then you have, moving medially, you have the posterior cutaneous nerve of the thigh, and then medial to that, you have the inferior gluteal nerve artery and vein neurovascular bundle. You can also tell the inferior gluteal nerve artery and vein bundle because it's going into what it innervates, which is the gluteus maximus. Probably you're going to have to cut it to get the gluteus maximus reflected completely, but you will still see these going into the gluteus maximus. If it doesn't go into it, it doesn't innervate it or feed it with blood. Good point there. Then if we have an inferior, we have our superior gluteal nerve artery and vein, and this comes out over the superior edge of the piriformis. You might be able to see a little smidgen of it above the piriformis, but when we reflect the gluteus maximus, as you can see on the right image on your screen, or the gluteus medius, I apologize, to see the gluteus minimus, you will then see that neurovascular bundle. The superior gluteal nerve artery and vein like to stay sandwiched between the gluteus minimus and the gluteus medius, both of the muscles that they actually innervate and feed. Now, lastly, we need to talk about a neurovascular bundle that really doesn't have much to do with the gluteal region by innervating it or feeding it, but it is important and it's one of the structures you will have to find. So to find the structure, you need to find your piriformis, then you need to find your sacrotuberous ligament. Remember that ligament that's going from the sacrum to the ischial tuberosity, going from that superior to inferior direction. If you look kind of just behind the sacrotuberous, you will then see the sacrospinous. So kind of sandwiched between the sacrotuberous and the sacrospinous, you will find something called the pudendal nerve and the internal pudendal artery and vein. It splits the sacrotuberous ligament and the sacrospinous ligament. That's how you're going to find it. Now, the pudendal, basically it means shame area. So it's going to go to your gluteal region and kind of and give innervation and arterial supply there. Again, nothing to do with this lecture particularly, but this is how you find it. So the big ones that you need to know are superior and inferior gluteal nerve and artery and vein bundles. You need to know the sciatic nerve, the posterior cutaneous nerve of the thigh, and the pudendal nerve with the internal pudendal artery and vein. Like I said before, most of these have the same nerve, artery, and vein names. Pudendal is one of them that is not. So keep it straight where pudendal is the nerve and internal pudendal artery and vein is the arterial and venous supply. If it helps you, internal has an A where pudendal doesn't. So internal A, that's an artery, and artery and veins almost always go together, if that helps you any. Okay, so using these, one thing that is common in the gluteal region is giving an intragluteal injection. So a lot of times steroids, so like if you have gotten into poison ivy or oak and you need steroid injection, you get a butt injection. A lot of other injections are giving in this region, but because you have all of these nerve bundles and they are kind of superficial, especially when you talk about a little needle being able to pierce something as big as the gluteus maximus, you need to avoid them at all costs to save your patient some pain. And so one way to do that is to inject into the superior-lateral quadrant. And to do this, basically you find the PSIS, so remember that protrusion on the posterior side that leads into the iliac crest, and then find that and go all the way to the greater trochanter. The PSIS is a little harder to palpate, especially in patients, but finding the greater trochanter and laying your thumb on it and then kind of spreading your fingers in a like a high five type of situation, you should be able to find that superlateral quadrant. And then injecting between basically your index finger and then your middle finger will pretty much keep a injury to something like the superior gluteal nerve, which is going to be the superior region. Don't ever give an injection lower because you could hit the sciatic nerve and that could be a ton of pain. So superolateral quadrant is where you want to give an injection in the gluteal region. Then just as a summary, these are all of the nerves that we've talked about. So inferior gluteal nerve, S1, S2, superior gluteal nerve, nerve to obturator internus, and nerve to quadratus femoris. If you notice, even though the sciatic nerve does exit in the gluteal region, it does not innervate anything really in the gluteal region. S1, S2 will be nerve roots off of the sciatic nerve, but it is not the sciatic nerve actually innervating the piriformis. The sciatic nerve is really going to innervate that posterior thigh first. That is the first structures that it's going to go to. So the inferior gluteal nerve is going to be innervating the gluteus maximus. S1, S2 is going to be piriformis. Nerve to quadratus femoris is going to be your inferior gemellus and quadratus femoris. Nerve to obturator internus is going to be superior gemellus and obturator internus. And then the superior gluteal nerve is going to be gluteus medius and gluteus minimus. I cannot express how important it is to find a way for you to study that helps you kind of block things out. You are going to find that there's going to be a lot of information, and if you can make little blocks, so gluteal regions, what muscles do I have there? List them. Okay, well, if it's piriformis and inferior, those are all lateral rotators. If it's gluteus maximus, no, that's my squat muscle, so that's going to be an extensor. And then gluteus medius and minimus, those are going to be my medial rotators and my abductors. And of like grouping them like that because in those groups, for the most part, they are innervated by the same things and they attach at generally the same areas. So that's kind of a tip I like to give. That is all for today's lecture. Have fun studying. We will see you all in lab. Again, remember that we have Zoom reviews on Fridays. So any questions that you have in lecture, please feel free to ask me or any of the other professors in lab or in that Zoom meeting. And also, always feel free to email. Have a good one. Injured hip. So Trendelenburg, always remember that injured hip means hiking. The uninjured hip will decrease. So two big key points on that.